Welcome. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar in the future, where it will be archived at www.nehatica.org. After completing this webinar, please upload and complete the quiz in the file pod to the left of this PowerPoint. You can also find it on our website at nehatica.org/webinar.html. You can email, mail, or fax the completed quiz. See contact info below. If you are a member of Nehatica NADAC, the certificate for this webinar is free. If you aren't a member, the fee is $15. You will receive a certificate worth 1 CE once you have completed and passed the quiz and paid for the webinar if applicable. Through co-sponsorship with the New Hampshire Training Institute on Addictive Disorders, this one-hour event is pre-approved by the New Hampshire Board of Licensing for alcohol and other drug use professionals. If you're having any trouble viewing the webinar, audio problems, or have any technical questions, please contact the Training Institute at 603-225-7060. You can find this phone number on the bottom of the screen throughout the presentation. For questions, please email any questions regarding the material you see today to traininginstitute@nehatica.org. So let's talk a little bit about core function number 2, intake. I will be presenting core function 2 today, and my name is Kelly Reardon. I'm the Associate Professor of Human Service and Addiction Counseling at NHTI, Concord's Community College. If you'd like to contact me with any questions regarding this webinar, my email is kreardon@ccsnh.edu, and please feel free to visit the college's website at www.nhti.edu. So I think in order to talk about core functions, we need to have a little understanding about its history. And since these core functions are archived at the Training Institute, I encourage people, if you haven't seen the first one, to go back and look at screening, because I talk a little bit in more detail about the history of 12 core functions and why it developed. But essentially, the 12 core functions of the substance abuse counselor was designed and put in place to improve professional competence and development amongst addiction counselors. It was a way for everybody to get on the same page to make sure we were all practicing uniformly. And the 12 core functions, if you're trained in that, allows you to do that. So you could even say we're all globally part of a club once we are ICNRC certified, because it says that we all went through the same type of training and we all understand how to practice competently in the 12 core functions. The global criteria is the criterion underneath the core function that is used to evaluate whether or not the clinician is skilled or competent at a particular core function. So typically a core function is defined as what the ICNRC defines it. And then underneath the core function is usually a set of global criteria. And these are the criterion in which a substance abuse counselor should be able to perform with competence. I will be referring to John Herdman's The 12 Core Functions of the Chemical Dependency Counselor throughout the presentation. I have referenced him at the end of this PowerPoint. I do recommend purchasing that book if you can, because it's a good reference book. It's good to have in your library, your professional library, because he does offer a lot of information about the core functions and also how to um, make sure you're acting competently in the global criteria. So let's look at everything up front. Here is the definition from the ICNRC for core function number 2 intake, along with the global criteria. So essentially this is everything we're going to be talking about today. So it's good to have everything right up front, and then throughout the PowerPoint in this presentation, we'll break things down and talk about them in a little bit more detail. So ICNRC defines intake as the administrative and initial assessment procedure for admission to a program. And the global criteria that comes along with intake, what a substance abuse counselor should be able to do in order to perform intake competently, is complete required documents for admission to the program. So typically, the programs, agencies have required documents that need to be done in the intake process, and it would be a substance use counselor's job to make sure they complete those documents. Number 2 is to complete required documents for program eligibility and appropriateness. So again, back in core function number 1, screening is done to show eligibility, to determine, eligibility and appropriateness. And in intake, you want to make sure you have documents that show that this person is indeed eligible and appropriate for your program. And third, you want to obtain appropriately signed consents when soliciting from or providing information to outside sources to protect client confidentiality and rights. Now remember, some of this might sound a little foreign. We're going to break it down throughout the presentation and give some examples to help you understand it. So the nuts and bolts of intake. So like I said, if you haven't already looked at the webinar on core function number 1, screening, I do advise people to do that because it will help you have an understanding of how screening and intake sort of build upon each other. Screening is the process, remember, where a client or potential client comes into an agency or calls into an agency and just they know something's not right, but they're not really sure maybe what's going on. So we would work with them to help them figure out if we are the right agency to help them with what's going on with them. So typically screening tries to rule out potential clients because we're trying to determine if they're inappropriate or ineligible. And intake is sort of the opposite. By the time screening has either ruled that they are appropriate and eligible, we start to do initial assessments at the intake process to rule in clients for treatment. So that's an important difference to make between screening and intake. Screening is usually trying to rule out potential clients as either inappropriate or ineligible. And at intake, we're doing initial assessments to try and rule in clients for treatment. The intake will determine whether or not the facility will admit an individual into treatment. Let's take a look at the global criteria now. If you remember from earlier slides, there are 3 global criteria. We'll break them down and look at them one by one. The first one is complete required documents for admission to the program. So, for example, and this could be different in different agencies, but typically there'll be some type of admission or intake form. And this is a form that will typically gather more information about the individual, including a more detailed substance use history. So in the screening process, we start the process of gathering information about a person to determine appropriateness and eligibility. But at intake, we're going to get a lot more detailed information. I have put an example of a very brief intake form on the next slide, and I'll talk about that in just a second to kind of give you an example of some of the information we start to look at the intake process. Typically, financial data may also be inquired about, and this would include any information about how the client might pay for services, any payment plans or sliding fee scales that the agency has will be discussed at this point. Insurance information would be gathered if that's appropriate. So any way for the client to pay for their treatment would be discussed at this point, and that can be varied. In order to be considered competent in Global Criteria 1, John Hardman says there's 3 things you should be able to do as a counselor. And the first one is report what forms are required within the agency in order to admit an individual as a client. The second one is relate the what and the how of the admission activity. Explain to the client what you're doing together and how you will do it. Sometimes giving a client a little heads up into what the process is going to be and typically about how long it will take helps to relax them and just feel like they're a part of their treatment. The third thing that a counselor needs to do in order to be considered competent is relate that the information was written down and documents were completed for admission to the program. Here in Figure 1 is an example of an admission intake assessment form. I do realize that the example is rather hard to read. I apologize for that. I'm going to try and give you a little of the information here. The top section where things look like they're highlighted in white is typically demographic information. So this would include who's completing this intake assessment, what's the date, and what's the time. We'll also probably gather vital signs at this point because we want to make sure that the client isn't in any health jeopardy at this point. If alcohol is smelled or suspected, we might take a blood alcohol concentration level measurement. But we'll also start to get more information about the person themselves. Where do they live? What's their date of birth? How old are they? What gender are they? And typically, if a person is female, then we will ask them whether they are pregnant or not, because we need to make sure that they're getting the proper care for the pregnancy. We'll also ask about, telephone, any ways that maybe who we would call if something was to happen to them, who's their, next of kin, that kind of stuff. In the middle section, it looks like a grid, and it's not highlighted at all, would typically be where the substance use history would go. So on the left-hand side, we might list some of the common substances used, such as alcohol, marijuana, cocaine. But you'll notice also down at the bottom, we leave 3 spots for other. So you would go through and ask about the common drugs, but maybe this person has, history with a drug that we're unaware of. So we would ask them, if I haven't listed a substance, if I haven't asked you about a substance listed here, what are some of the other substances you have history with? And let the client tell you about that. And typically what we would want to know for each drug is how did you use that drug? So if we're asking about alcohol, we want to ask them, did you drink alcohol? Yes. And we want to know how long did you use alcohol? How long have you been using alcohol? In what amount, in what frequency, and whether they have ever received treatment for that particular drug. So you would go through and ask those questions for all of the different drugs. So that's just a little sample of an intake assessment form. Very similar to a biopsychosocial. Actually, it's some of the beginning essentials of a biopsychosocial. So the second of the 3 global criteria for intake says complete required documents for program eligibility and appropriateness. So the intake form would typically be completed here. Most intake forms developed by an agency will cover the required information to determine appropriateness and eligibility. So here again, for example, we want to make sure that if our client before us is 17 years old, but our program only admits people who are 18 and over, then the client is not eligible for our program based on age. Again, we also have to determine if there is a substance use issue. Sometimes, our clients might have other things going on, and it's not necessarily a substance use issue, and we would need to make referrals at that point. So I talk a lot more in the core function number 1 screening about examples of appropriateness and eligibility. So I'll refer you to that webinar for more detailed examples. But those are the types of things we're looking for in the intake form. In order to be considered competent in global criteria 2 intake, a substance abuse clinician would need to first report what forms are required within the agency in order to document a client's appropriateness and eligibility for the program. And second, they would need to relate that information was written down, completed, documenting the client's eligibility and appropriateness for the program. The third global criteria for intake is complete required documents for program eligibility and appropriateness. So here I put 2 separate forms on here to talk about, and one is the release of information and the second is the informed consent. So since counseling is private and protected under federal laws with confidentiality, we need to make sure as substance use clinicians that we get permission from individuals and clients to speak to anyone regarding their medical health care needs. So even if it's mom or dad or husband or wife, federal law still protects our clients, and we are not allowed to have conversations with people unless we have a written release of information or other exceptions apply. And that would be covered under 42 CFR Part 2. The second document is the informed consent. The informed consent is typically a document that discusses what the rights of the client is, and that the client also has a right to be informed about what they can expect in their treatment, and that treatment is voluntary. They can make an autonomous decision whether they're going to go through with it or not. So the informed consent will typically talk about things such as what the rules of the facility are, what the client needs to do to stay in good standing, what the client can expect around a typical day in treatment. Maybe even confidentiality is discussed in more detail, again in informed consent. So it gives the client a picture of what they can expect and what we're expecting of them throughout the treatment process. In order to be considered competent in the third global criteria, a counselor would need to first relate knowledge, understanding, and the specific activity undertaken to explain the need for a client signing a form that allows the counselor to obtain confidential information from another source, or to be able to release confidential information from the counselor to a third party. And second, relate that a client signed a release, to whom and why. If no releases were signed during the intake process, the counselor would also need to document why that was. So we should talk a little bit about releases of information. because we need to make sure that as an agency we're using proper releases of information. So you can look at this in more detail when you look at 42 CFR Part 2. They say that the following information must be present in a release of information form. So I go through about 11 different components of the release of information. And essentially, you have to have the name, right, of the program or person permitted to make the disclosure. So that's your client. The name or title of the individual to which disclosures are being made. So who is the client allowing us to talk with? What is the name of our client? And what's the purpose for the disclosure? Why are we talking to whomever we're talking to? How much and what kind of information is to be disclosed? So just because we have a release of information in place doesn't mean that we just talk about every single area of a client's life, their personal history, etc. We ask the client, what exactly am I allowed to talk to somebody else about you? There has to be a signature from the patient, a date on which the consent is signed, an expiration date, and also a statement that the release of information is subject to revocation at any time except to the extent that the program has already acted on it. When programs operating under 42 CFR Part 2 disclose information pursuant to a consent form, they must include a written statement that the information cannot be redisclosed. So this isn't a webinar about confidentiality, releases of information, or redisclosure, but if any of this sounds foreign to you, then you should absolutely be doing some work into looking into 42 CFR Part 2 and what it means to your agency. But I just wanted to give people a quick look at the different components of a release of information. So we should also talk about, excuse me, some possible barriers to consider in the intake process. So just like in screening, it's a very vulnerable time for our clients. They're not sure what's going on. They're not sure if they can be helped. Life is turning upside down for them. Things are very uncertain. And this is the beginning stages. You know, they've gone through the screening process, they've been deemed appropriate and eligible, and now they're coming into the agency ready for treatment. And it's very scary for a lot of our clients to have to do this. So we really need to make sure, acting as competent counselors, that we have awareness and sensitivity to the fact that our clients are going through a whole whirlwind of emotional experience at the time that we are intaking them into the program. And it's our job to make them comfortable, to offer them encouragement, to help them, ease some of their anxiety and give them hope. So, you try and put yourself in their shoes. How would you want to be treated, right? You would want someone to welcome you, be kind with you, be patient with you, speak at a reasonable rate. This is our job for a lot of us, so we could probably do an intake in our sleep, but we have to always remember that our clients don't hear this stuff all the time. They can't recite intakes or releases of information in their sleep. So we need to make sure that, we speak, slowly, calmly, and we always encourage questions. So anytime we give our clients a little bit of information, we should take a pause and just make sure that they're processing and see if they have any questions. Make sure they're still with you. So we really, really need to be sensitive at intake and be aware that our clients are probably going through quite a few obstacles in order to come to treatment. So we really want to make sure we're present for them. We need to also take the time out of our busy schedules, answer questions clearly. I think in my experience looking at the intake process, you as a substance use counselor, you might come in and you might have 10 people lined up for intake that day. And so you're thinking, I'm busy, I have to get these 10 people in, I got to move people along. But I think what's missing there, speaking about awareness and sensitivity, is it isn't about getting all of our people in, but it's about getting each person in with sensitivity and awareness. Slow down, be clear, be patient, and be kind, right? Remember that our people are going through a lot of things right at that moment, and we'll take the time to talk about some of those things that our clients might be going through. But these are people. These are not objects to just be moved along. So really, I implore you to make sure you try and be present, have awareness and sensitivity when you first, you should at all times, but particularly during that intake process. So looking at some of the things that our clients may be experiencing, we need to consider the fact that our clients are usually coming to us with more than a substance use problem. They're coming to us with a history. And we need to have some awareness that they may have a fear of the treatment process. Believe it or not, the work that we do sort of has this mysterious tone to it, right? We work behind locked doors. We work behind closed office doors. We work under confidentiality. We're not allowed to talk a lot about the work we do, or especially the clients we see with other people. So people who aren't in our profession sort of aren't sure, what we do, how we do it. They don't have the awareness about the process. So when you're unsure about how things will work, or you've heard things about how counseling works, it can be scary for people. So they might have a fear of, what to expect. Another thing to consider about the treatment process is that this may not be the first time that a client has come to treatment for a substance use problem. This may be the third time, maybe the fifth time, might be the 10th time, and it might be the 50th time. So we have to take into account that even though they may understand the process a little bit more, they're afraid that it's not going to work. I've been through this 50 times. What makes, the 51st time a possibility? So it's really up to us to have that empathy that they're afraid of going through the treatment process one more time and it not being successful for them. That's a real fear for our clients. Our clients might also be really confused. We have to remember that some of our clients, they could have untreated co-occurring disorders, which can add to the confusion of a new treatment facility. But the other factor to consider besides the co-occurring is that our clients may begin to detox during the intake process, and they might already be going through the detox process. They might still be feeling, a little unwell, feeling ill. They might really be feeling awful, actually. So we need to take that into account. When you're not feeling good, how open are you to new information and trying to really, digest what a person's telling you? It makes it a lot harder when you're not feeling well, right, to be present. So that's why we also need to make sure we repeat ourselves if we need to. We pay attention to the nonverbals. If we look like we're losing our clients because their eyes are glossed over or something, we need to really make sure we take that time to check back in with them and get them present with us. Some of our clients may also be suffering from short-term memory loss, right? We know that substance use concerns may lead to short-term memory loss. So really try and have some empathy and some patience if the client has you repeating things. Remember, there could be some short-term memory things, there could be some confusion. It could just be overwhelming for them. but they have to understand, they have the right to understand what they're undertaking as part of treatment. So we really need to take the time to slow down, be clear, and let them know what they can expect with treatment. Some of our clients might be going through some fears about who's going to take care of their children or their family while they're in treatment. You know, we're busy thinking about trying to get our 10 intakes done that day, but we have clients sitting across from us that are trying to think about how their children are going to be cared for while they're in treatment. This typically is a large fear for a lot of women. And the children may be safe with somebody, but it's still, you know, being a parent, it's if it's not you there to care for them, you always worry about them. So that's a really big concern for people, not just women, but men as well. And legal issues. So our clients, you know, may come with concerns about either current legal issues, pending legal issues. They might be on parole. There could be a whole host of different things going on for them. And it's pretty difficult to be 100% present, 100% calm and paying attention during the intake process when you think you might be facing, you know, 5 to 10 years in the state prison, right? So we need to take that into account. We need to know that our clients don't just come to us with one specific substance use problem. They come to us with a host of different problems. And those problems, even though they might be temporarily suspended while they're in treatment, are still in the client's mind. They're still thinking about those things. So we need to have some patience and empathy with that as well. Our clients could also be thinking about medical concerns they have going on. Our clients can have a wide range of medical concerns, and just to name a few, maybe hepatitis C, HIV, AIDS, they could be pregnant, it could be liver disease. So we really need to make sure, and sometimes our clients are diagnosed with those things, but sometimes our clients haven't sought medical care in a number of years. So they might think they have some of those issues, but don't actually know. So they worry about that as well. So we really need to consider our bedside manner when thinking about medical concerns that our clients might be having. Financial concerns. You know, some of our clients have no money, no job. They don't have people to support them financially or socially. They're worried about how they're going to pay for treatment. They're worried about how their families are going to get supported financially while they are in treatment. So if a person is the primary financial supporter for a family and they go into treatment, who's going to pay the rent? Who's going to pay the electricity, the daycare, all the things that, you know, your client might have been paying for while they were working? So those are big concerns. Is my family going to be okay financially while I'm in treatment? Employment concerns, right? So some of our clients, um, they could be thinking about the fact that they just got fired before they came into intake because they came to work high or didn't show up to work because they were high. Um, and then they're worried about what's going to happen once I leave treatment. You know, what will I do for work? And this can be a huge concern. It sort of goes with the financial concern. If I don't have a job, how am I going to be able to support myself? How am I going to be able to support my family? What will I do? And sometimes our clients might be concerned because they might have a felony charge. So they're very concerned about how they're going to actually get employed and, you know, restart a life. Those are big, big things to thinking about and worrying about while they're trying to do the intake process. Also, our clients may have a lack of support from sober family and friends. Um, let's face it, our clients tend to burn bridges with family and friends when they have substance use problems. But imagine what a person might be going through if they have no one to talk to, no one that will be visiting them, no one to encourage them while they're trying to, make a better life for themselves. It's a very lonely, isolating thought. So very, very hard to go through that when you're going through the intake process. And lastly, and I'm sure there's a million more concerns that I haven't listed here, but our clients might be going through a lot of feelings of shame and guilt and fear about finding out about past issues or ramifications. So during the intake process, we could be asking them questions about things that they've done in the past. And it can be really hard for a client to, think back on those things and to talk about them with you. It could bring up, feelings of shame and guilt. Um, so lots of things to consider that might be going on with our clients during that intake process that might, you might think they're being resistant, but there could be all these things plus many, many more going on at that process. So again, having that kindness, that awareness, to just, be sensitive, be empathetic, and understand that it's a multidimensional problem. Addressing possible barriers and decreasing client fears increases the chance of obtaining accurate data from a client. So this is a key point that people should remember. Having that awareness, having that empathy, building that rapport and trust up front helps, maybe reduce some of the feelings and fears that the client might be going through because of those barriers, and then they might actually, give you more accurate data, be more open to the treatment process. I think it's also important to talk about the clinical interview process. So during the intake, you are trying to gather information from a person by interviewing them essentially, and there's skills you need in order to obtain information from people. Um, you have to gather the data. An intake typically involves a lot of paperwork. So, depending on your agency, you'll have the intake assessment forms, you'll have the financial data forms, you might have a whole host of forms, and you're also beginning, the sort of biopsychosocial interview at this point. So, if you have a lot of forms that you need to get through in the intake process, be organized, right? Get your forms all ready, have them neat and organized, and have them in order of how you're going to gather the information. I mean, it just really makes the process less distracted. If you have everything neat and ready to go, then the client's not, waiting for you, wondering about your own competence. So you really need to have a balance um, to completing the paperwork with establishing rapport with the client. And that can be a really tough thing to do. So some of the things you want to try and do during the clinical interview process, and you might not be able to reach all of them, but you shoot for them, you aim for these. Try and allow no interruptions. So maybe that means if you can, turning the volume down on your phone, closing the door, or letting people know that you are in session. You're making sure your own personal private cell phone is off. Computer screen is maybe down if you're doing paperwork, so you don't have things interrupting you. And give your client your undivided attention, right? As much as we want our clients to be present and with us, we have to be present as well. We don't want to make our clients repeat things because we're not paying attention the first time around. So make sure you're not distracted and you give them your undivided attention. Make eye contact with the client, right? So let them know I'm here, I'm listening, I'm paying attention to you, you're important. Provide for the client's physical comfort. So this might be, just making sure that the seat is comfortable for them, or if they're in a wheelchair, that there's access to a spot on the desk where they can write and they don't have to wheel around things or bump into things. So making sure that the client actually feels physically comfortable. Ask them, is it warm in here for you? May I open a window? Would you like that? Just simple comforts like that can really help put someone at ease. If you can, avoid sitting behind a desk. It kind of acts as a physical barrier between you and the client. And it could also sort of play a little bit more into the power differential, right? I'm the counselor behind the desk, you're the client. So we want to try and reduce that as much as possible. And again, that's about comfort for the client. Keep the interview on track if the client digresses. So sometimes our clients will start to go off on tangents when we bring up a subject because they might have a lot to say about it. But you want to try and make sure you stay on track with the interview, get the information that you need, and then when they have appointments with you one-on-one, you might be able to bring up some of the things that some of the tracks that they went off on and talk about those as well. Don't be judgmental, right? I think that doesn't need a whole lot of explanation, but sometimes our clients may say things that, you don't understand or you don't agree with, but that's not your job, right? Your job is to be non-judgmental, to be open, to be empathetic, and give them the help that they need. Be accepting and encouraging. Work on building that trust and rapport. Like, I can't say that enough. We talk a little bit more about empathy and rapport later on in the presentation, but those are essential elements in working with people. And ask for clarification when necessary. If you don't quite understand something, don't just write it down, because remember, you're going to have to report back on this. So you want to make sure you have that clear picture. You want to make sure you really understand what your client is trying to tell you. Try and use a combination of yes, no, and open-ended questions. So try and use that combination of closed-ended questions and open-ended questions. But try and limit the questions as well. Don't just fire questions off at a person that can really make them feel like they're being interrogated. And that doesn't help with the trust and rapport. Don't be uncomfortable with client silence. Sometimes it could simply just mean that the client is thinking about their response to your question. I think we're very quick to be go, 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 and we don't give people sometimes the time to think about what they want to say, or a memory might be coming back for them about a question you asked. So, give those few seconds for them to gather their thoughts, to think about what they want to say to you, and don't be so quick to fill silence. You also want to establish rapport. So you want to, use a pleasant tone of voice, maintain your eye contact, and, use your personality, right? We're human beings. And I think that, I often talk about counseling as a science and an art. There's a science to how to do a clinical interview, and the art comes in with you. Right? I will never do a clinical interview the same way as you would do a clinical interview, because we use our personalities, we use our senses of humor, we use our own self sometimes to do the clinical interview process. So it's going to be different for everybody. Just show you're human. Have some cultural considerations. Have knowledge and sensitivity about a client's background, ethnicity, and culture. You're not going to know every single different ethnicity, background, and culture, but having just a little bit of knowledge about a variety of them is good. And if you don't know, ask. Have some understanding about gender differences. Be sensitive to the different treatment needs of women, men, heterosexual, homosexual, and bisexual, or transsexual clients. Right? Body language, make sure it's open, right? You're not sitting there with arms folded over your chest. It's inviting and it's square. So your feet are planted on the floor, your hands down by your side, or for some of you, you'll be writing with it, but really try and show that you're open to the person. And give your client, some encouragement. Validate what they're saying. Give them some genuine compliments. Be sincere. Don't give compliments just to give compliments, right? I think people can read through that. Make summary statements. So if a client is giving you a rather large amount of information right off the bat, you might want to interject and just do a sort of summary of what they just said. It shows that you actually understand what they're saying, that you got what they're saying, and give the client the opportunity to say, yeah, yep, that's what I'm saying, or no, that's not what I meant, right? So it really helps the client feel like they've actually been listened to. And I already talked about open-ended questions really help the client talk. And then you want to use closed-ended questions to try and get a client to be more specific about a topic. This is just a cute little cartoon I use in some of my work with students. And it's a doctor over a hospital bed, and the woman is lying in bed in the hospital, and the doctor says, "Of course I'm listening to your expression of spiritual suffering. Don't you see me making eye contact, striking an open posture, leaning towards you and nodding empathetically?" So it's just, again, it's like, watch that bedside manner, really make sure, oh, I'm making my own eye contact, but there's a difference between, again, that science and that art of it. We know that the science is, good to make eye contact, have an open posture, but putting yourself to it, having the art behind that is the most important thing. It's human. Here are some of the different aspects of the assessment. These are typically done at intake. This is part of the information that we try and get. This is the more detailed information we get. We typically are looking for the presenting problem, right? What's the chief complaint? Why is the person here in our facility? What is their substance use history? What is their family and social or leisure history? Who's in their family? What makes up, who's in their social system? What do they do for fun? Educational and employment history. What's the highest, level of education they've received? Do they have any learning disabilities? Who was their last employment? Things like that. We want to know a little bit about their legal history too. Mental health history, in case we might need to make a referral if we're not a co-occurring agency. Their medical history, last time that they saw, a primary care physician. Do they have any concerns about their medical status at that point? We also want to know what our client's strengths and limitations are, and sometimes we can do that through asking them something called a SNAP. And SNAP stands for strengths, needs, abilities, and preferences. So these are some of the components that can be included in the clinical interview or the assessment. There can be more, and there's definitely, you don't just ask, well, what's your family history? You ask them, so who makes up your family? Are you married, widowed, divorced, separated, never married? Do you have any children? So you really try and get specific about who makes up the family system. Like legal history, you want to know. Have you ever been in prison before? What are some of the charges? Have you ever had a violent background? So really getting specific in each of these categories to make sure you have a good understanding of the person. So here we kind of break this down a little bit, but presenting problem. Why is the client here? What's going on in the client's life that they feel they need to seek treatment for it? Why treatment? Why now? So what made it so bad that now they're coming into treatment? And if they've been in treatment, by the way, ask them, maybe a little bit about what's different now. You know, you've been through treatment before. Why do you think coming back to treatment would be helpful? Okay, it's time for a poll question. So the first poll question we have is, during the intake process, a clinician screens for appropriateness and eligibility of the client. So I'll give you a few seconds to answer that. Okay. So that's false, because during the screening process is actually the time to determine appropriateness and eligibility. But appropriateness and eligibility does continue into the intake process, but it's not where it is determined. That would be screening core function 1. Okay, so again, looking at some of the components of the assessment, we're looking now at substance use history. So we want to ask our clients, what substances have they used in the past 24 hours? How much? How did they use the drug? So some examples of that might be oral, intravenously, intranasally, smoking, right? Those are all different methods of ingesting a drug. You want to ask about the past 24 hours, but also over the past month and then the past 3 months. You might want to ask if the client has ever experienced a drug overdose or withdrawal symptoms. Has the client ever had treatment or spoken to a counselor about their substance use issues before the interview? And have they ever been in prior treatment or detoxification for a substance? Okay. And there's probably a whole host of different questions you might have to ask under the substance use history, but those are just a few examples. Family, social, leisure activities. Does the client have any support systems? Are any of these people sober or without addiction? Does the client have somewhere to go after treatment that's safe? Does the client have activities that don't surround using? Okay. Educational and employment. What is the last grade that the client completed? What's their primary language spoken? Does the client, do they know of any learning disabilities? Do they suspect that they might have any learning disabilities? What were their peer relationships like? So again, also asking about military history as well. Legal history, I kind of talked about this already, but we want to know about pending legal charges. Do they have a probation or parole officer? Violent crimes, that kind of stuff. Mental health history, it's kind of self-explanatory, but we want to know, have they ever been seen by a mental health clinician? Do they have any diagnoses, any depression, anxiety, things like that? Are they on medication for a mental health issue? So again, really trying to get the nitty-gritty on their mental health and medical. So same thing, when's the last time that they saw a doctor? Do they know of anything that they're diagnosed with? Do they take any medications? So you can tell this might be a lengthy process trying to get all this information. And building rapport. I told you this would come up again, and we do hear this all the time, right? Rapport and empathy are so important, but what do they actually mean? Merriam-Webster says that rapport is a close and harmonious relationship in which the people or groups concerned understand each other's feelings, ideas, or communicate well. Well, that's a lot, right? But we aim for the top there. But sometimes rapport can happen very naturally, when you just sort of hit it off with a person or you get along with them right away. But some other times you're just going to have to really work at it and build it through trust, empathy, and honesty. Some skills on building rapport, again, maintaining eye contact, using that positive body language that's open, listen, nod, smile, make encouraging statements, be genuine and honest, admit when you don't know something, and make sure that judgment is completely intact. Make sure you're being non-judgmental. Building empathy. So thinking about you want to create a safe and nurturing environment for the client in your workspace and in yourself. So make sure your office is tidy. You don't have junk laying around everywhere. It's free from personal objects, and it should be comfortable, right? So again, that temperature piece and all that. Don't make sure it's not cluttered. The counselor for yourself should also be calm, friendly, and welcoming. Use verbal encouragers like tell me more and nonverbal encouragers. And an acronym we use at the school when teaching interviewing is SOLAR. So make sure your body is square, open, lean forward slightly, maintain eye contact, and be relaxed and ready for whatever's going to come out of your client. Make sure you're practicing active listening, really trying to understand what the client's words and nonverbals mean. Be present in the moment with the client. Really try and walk the path with the client and try and experience what they're telling you. Time for another poll question. So, number 2, during, oh, this looks like it is the same one. Okay, here we are. Number 2, childcare issues can be seen as possible treatment barriers for clients, especially women. True or false? I'll give you a second just to answer that. And the answer is true, right? We've talked about the fact that mostly women can sometimes be very concerned about who will take care of their children, who will take care of their home while they are in treatment. So now we have, I looked around on YouTube for a possible intake interview just to give people an idea about what an intake interview might look like. And this was the best that I could find. It's about 9 minutes long. So we'll go ahead and show that. Okay, I think we're experiencing a little bit of technical difficulties on the interview, but we're going to go ahead and put the link to the YouTube intake interview in the chat box. So if you're interested, you can check that out. This is the end of the presentation on core function number 2, intake. I hope you've enjoyed it. And again, if you have any questions, please feel free you can email me directly or email the Training Institute on the email posted at the beginning of this presentation.